everybody. This is Megan Murphy with Adirondack Health Institute, and I want to welcome you to the DSRIP Project 2DI webinar. I think this project has one of the longest project titles in DSRIP, so I won't go ahead and read the whole thing. We're calling it patient activation. And so if you look at the next slide, we're going to go through the agenda. We just want to go over the high-level overview of the project. 2DI was one of the projects which Adirondack Health Institute was an Adirondack Health Institute-led project. So one of the things that's going to be a little bit different about this webinar is that we want to go through the project plan as it was presented to the Department of Health, and help you understand what we did submit for that. And then we're going to go through a timeline of the due dates, the work plan, the speed tables, the budget, project champion, and next steps. So a high-level overview of 2DI. I just want to remind everybody quickly of what this project is trying to accomplish. Apparently our slide deck has its own, it's on its own timing. We need to go back. So one more. So we're going to go through a high-level overview. The project is focused on people in our communities that are not utilizing the healthcare system, and we're going to work to engage and activate those individuals. They've required us to use a formal system for doing that, and the Department of Health is urging us to use a product called PAM, which is a patient activation measure product. And so that will enable us to collect the data that we need on the folks in our communities that we are able to engage with. And so there's three primary concepts for this project. We need to work on patient activation. We need to look at the financially accessible healthcare resources in our communities to be sure that people are able to access care. And we need to look at partnerships with primary and preventive care services. And I wanted to give everybody just a quick overview of the Pam tool. It's a patient activation measure. It assesses and gauges the individual's knowledge and skills and their confidence in managing their own health care. What it essentially does is once someone has gone through the questionnaire, the PAM questionnaire with somebody, they are essentially assigned to a level, and this helps us understand where they are and the potential of engaging them in improving health outcomes. And then ultimately the goal would be to move them up the scale from obviously level 1, which is disengaged and overwhelmed, up ultimately to a level 4 where they're actually better engaged in improving their own health outcomes. I just wanted to also say this is where I wanted to let you know what we've submitted to the Department of Health. Section 1 is the community need piece of this, which helped the Department of Health understand why we chose to engage in what is known as the 11th project, 2DI. We have here, when we look at our social determinants of health, as we've talked about in the past, we have high rates of poverty, low rates of higher education, and we do have some access to care issues. All of these creating issues for people in improving their own health outcomes. Section 2 has the populations to be engaged. We were actually given these numbers by the Department of Health. The total of 32,615 non- and low utilizing Medicaid recipients comes from the Department of Health. Roughly about 16,000 of those are actually non-utilizing Medicaid recipients. We know that. And then we have 50,166 uninsured. in thinking about implementing this project plan, looking at those non and low utilizing Medicaid recipients will be a little bit easier. These are determined by the Department of Health, who is non and low utilizing, and they obviously have information on these people, and so that will help us as we implement. We will be able to be in direct contact with them. The 50,000 uninsured, what we're doing now is we're working on some better information and data about who are the uninsured and how we might best approach them to engage them in the system. In Section 3, we have community assets and resources to be mobilized. We talked about how we would build on existing partnerships to implement this project. As you know, we have a very engaged primary care medical home project, the health home project, behavioral, we would utilize behavioral health folks involved with DSRIP, public health departments, social service departments, hospital emergency departments. So these are all partnerships that we have through various programs at AHI. We also have relationships with the tobacco-free networks and other networks in the area. And AHI also has a health navigator program signing people up for health insurance here. So those are all existing resources that we felt would be useful in implementing some form of implementation plan. We would like to build on new partnerships for this project. We feel that the way to, and in talking with a lot of our partners, I think what the discussion has been is to reach people in non-traditional ways, looking at some of the more traditional places you might think of for approaching people, food banks and homeless shelters, things like that, but also looking at other more non-traditional partnerships such as universities and colleges when we're looking at, say, a younger uninsured population, veterans groups, businesses, correctional facilities. I think these are places that we have not been as effective reaching out to, and we think would be important in trying to reach the people that we would like to reach to get coverage with this program. One of the things we would very much like to do is look at the data and look at where we will find these people to try to target our resources, especially that Medicaid data. Obviously, we will be able to see zip code level data, and we would know which community-based organizations might be the most appropriate to partner with. And that's why we're looking into the uninsured data to try to figure out if we could get something as detailed as that to understand how to best use our resources to reach the maximum number of people. And just to let you know, you can read the complete project plan at the link there that shows you that's the whole DSRIP application. So we've invited you all to this webinar, and so the next question always is, so what do we need to do? The first thing is we're drafting a, we have to draft a plan for the Department of Health, and that is essentially, they're not actually looking for a traditional implementation plan the way that many of us are used to submitting. They're really looking for an abbreviated information that has to do with risks and mitigating those risks, and then some of the time frame for the speed of how quickly we're going to be implementing. So we would like to get a draft of that timeline to KPMG on March 9th. And then we need to get a budget template to AHI on March 13th. And then what will happen is once we've given the draft Excel file to KPMG, they will actually give it back to us with some feedback. And from there, what we'd like to do is re-engage this group to talk about the feedback, and then ultimately improve the project plan to be submitted to the Department of Health on April 1st. So I did send out an Excel file to the group, and that has what we started drafting a work plan, and basically that's just a framework. DSRIP is a very prescriptive program, and so there's a document on the DSRIP site that's called Metrics and Milestones. And so with each and every one of the DSRIP projects, they have required metrics and milestones. And so our first thought was, let's put those into a work plan format so that we understand some of the expectations, things that we will absolutely have to do to meet the metrics and milestones for the Department of Health. So we've just frameworked those out in an Excel spreadsheet. But I think what we would like to see is some regional influences. And so we'll be working on that over the next week or so. And then I also included the project speed tables. And so I'm actually going to hand it over to Colleen Florio because she's a much better expert at the speed tables than I am.
Okay, thanks, Megan. I'll take a stab at going over the project speed table with you. So I understand that you already have the Excel file that shows the project speed as well as the project scale. So speed refers to the pace at which as a network we're going to be able to meet all the project requirements. So how quickly are we all going to get up to speed and meet all of the requirements? And what you see in the top portion of the Excel spreadsheet is under project implementation speed, you see a red X at DSRIP year 2, quarter 4. So what that red X represents is a speed commitment that the PPS network as a whole has already made to the Department of Health. So back in January, we had to submit some speed and scale information, and at that point in time, we indicated that all of the various organizations that are taking part in Project 2DI would in fact meet all of that project's requirements by the end of DSRIP year 2, which is actually by the end of 2016. And in a minute, actually I'm not sure if you put the tape there. So DSRIP year 2 would be the same as calendar year 2016. And what we would be looking for at this point in time would be for the different organizations that are all taking part in Project 2DI, we know that all of them as a group have to meet that point where the red X is. But if some of the organizations that are taking part will meet all of the project requirements earlier, then we need to know what point in time on this timeline that would be. So I think what will happen next is we'll be working with the different organizations that we're really building this project right now. So with the different organizations that will be implementing the project, when will they be fully, or have staff recruited, be trained, and have most of the requirements in this project are about that startup point. So for project speed, we'll be looking to determine at what point in time each organization that's taking part can commit to meeting all the requirements. Ideally, DOH wants to see kind of a ramping up. So what they're looking for is that we're working with several organizations and that some of them will probably meet the requirements a little earlier than others. But overall, they would all have to be by that point in time of the end of 2016. Then it gets a little more interesting when we get to the speed section. To the scale section. So when it comes to how many patients, that's the scale of the project, and the actively engaged definition for this project is, Megan discussed, is the number of individuals who have completed that PAM. And again, the numbers in red are the numbers that the PPS has already committed to at the PPS network level. So we were required to show patient engagement that built over time to reach the total number of the population that DOH identified. So that's why it builds up to that 82,000 number at the end of DSRIP year 4, is that would be all of those uninsured plus non and low utilizing Medicaid patients. So clearly the state, has set the goal for us that they've set, obviously a very ambitious goal, but that is the goal that they have set, which is that we were required to show that we would in fact be engaging 100% of the target population. So back in January, when we submitted numbers, again, those red numbers, we had to submit them based on 6-month periods instead of quarters. So that's why you don't see, that's why there's a number there kind of in every other box, is we only had to do it based on 6-month periods. And the way that these numbers are counted is, basically that they reset to 0 at the start of any given year. So basically what we committed to was that by the end of this year, DSRIP year 1, which begins April 1st, 2015, that by the end of 2015, there would have been 10,000 persons who had completed a PAM. Next year, within the first 6 months of the year, you see 35,000. By the end of the year, 50,000, and so on across the measurement years. What we need to do now is to show DOH the commitments by quarter. So ideally, we would tie those quarterly commitments to the specific organizations that are part of the project. I know that the project team is being built. We're looking at at different organizations that might want to be part of implementing and of doing the activation and engagement activities and completing the PAMs. So eventually we would need to have our full list of organizations that were taking part and the numbers that they've committed to. I'm not, given that this team is a new team and is just developing, and since we have to submit follow-up numbers for April 1st, I'm suspecting that we won't have that organizational level detail right now, but that will be, again, providing projections for the project as a whole.
Right, and I think the one thing Colleen and I talked about at one point was, although the numbers seem rather large, we're hoping that as we're more and more effective, that number of 82,000 is actually reduced. So it's really just meeting the spirit of the idea that we're trying to get out and touch as many of the people that are identified as uninsured or low or non-utilizers of Medicaid. But, it does look like a really big and daunting number right now. We'll acknowledge that. But the hope is that as we do more and more work, that number gets smaller and smaller over the years. So one of the things that we were thinking about here was things to be putting in the budget, and I'd like for folks out there to be thinking about, how would we possibly go about implementing this and some of the things that we might need to do that. And I do think we need to be very creative here. We were thinking that there does need to be someone managing the project, and that would be one of the personnel costs. And you would see in the project plan that in the metrics and milestones, the department anticipates that we would be hiring navigators. There's a whole piece of the project plan that talks about that. And so one of the things, as we've discussed it here at AHI, we have a very large rural region here, and hiring a whole lot of people to go out and cover the region may not be the best model for this. What we've been thinking here is more about partnerships with existing community-based organizations. We think there can be some navigators, people who are sort of like your super users. They know, and they can go to some unique places and work with people and use that Pam scale and potentially other techniques to help get people signed up and into the system. But one of the ways we've really been conceiving of this here is how can we partner with organizations that are already doing work with individuals that we know are crucial to impact. And so you'll see number 4 under non-personnel would be contract costs for CBOs. It's that idea of can we utilize the time of an already existing staff person at a community-based organization and pay them for that time, depending on how many, Pam scales they've been able to do there. So that's been one of the concepts that we've put forward thinking about how to do this. We would definitely, the budget would pay for the training. We do think there would be a need for a media, marketing, PR campaign. There would also be need for outfitting staff. We don't know exactly what that means yet, but computer, software, that kind of stuff. Rent, utilities, supplies, travel, meeting costs, those types of things. So that's been our first kind of thought to sort of give people something to edit off of rather than just putting it out there and saying, what do you think we should put in the budget? And then if you've been on some of Colleen's other webinars today, you'll know that we have a concept out there called the Project Champion. And the Project Champion is, we're developing a scope of work for that, but we do have somewhat of a concept of that here. We're looking at approximately 0.2 of a full-time equivalent. That's what we think would possibly be the amount of time that person may spend on being a project champion for one of the DSRIP projects. The project champion is going to be a subject matter expert. They will provide some leadership in the project implementation. They would participate in statewide learning collaboratives and sharing information with the teams and helping to set agendas. But they would work very closely with an AHI project manager, and they'll handle scheduling. The project manager at AHI will handle the kind of the logistics, scheduling meetings, communications, preparing materials, and documentation in the DSRIP tracker and other reports that need to be done. And I think particularly for this project, we see initially there might be quite a lot of work, but I think as you work hand in hand with the AHI project manager, I think there would be a lot of shared responsibilities there. And so we also wanted to ask this group, who else should be on this committee? Our EASE specialists, our EASE director wasn't able to be here today. She's at a different meeting. She's at a training. But we were trying to think, food pantry, chamber of commerce, public housing. There's a lot of potential places to interact and places where community-based organizations might be glad to partner with us to bring additional services to the people they serve, and also to help support their staffing with the community-based contract. And so I was thinking that people could send me an email or contact me about who you think should also be on a work group. And then the next steps are, we need to draft the work plan and budget, and we'll send that out to the group for review and feedback, and then we'll set up a conference call to review the KPMG feedback. So I think at that point, that's our big overview of 2DI. Does anyone have any questions? So we're not seeing any questions. We want to give it another minute to just be sure. I know that this is absolutely new to a lot of people, so we want to be sure we have time to be sure we answer your questions. But absolutely be sure that you email me with any input that you might have, budget, with who you think should be part of this as community-based organizations. And, we'll be in touch. I did email quite a few of you before the webinar with the slides and the draft project plan and the timeline, the speed timeline. So we just want to be sure that we'll get that out again to whoever joined a little bit late, registered late for this webinar. And we'll also be posting this information to the blog. So we don't see any questions. So we appreciate your attendance, and we'll be talking to you. Thanks.